Hi everyone, my name is Dr. Obeng-Frimpong and welcome to another episode on the TutorMed channel where everything medicine is simplified. In today's video, we will discuss some tips for the history-taking OSCE station using the simulated exam we posted last time. We will discuss that case in particular and suggest some approach to taking history in the manned OSCE exam. It means to get the most out of today's video, you should have watched our previous video. The link to that video is in the video description below. Kindly have a look at that video if you haven't done that yet. And please do not forget to like and share this video and subscribe to our channel if you are yet to do that. Alright friends, let's get started. Well, and so let's look at the OSCE station again. A 65-year-old man presents with a 3-day history of chest pain and cough with streaks of blood. The instruction was, take a focused history for this patient, arriving at a diagnosis. And so usually for this manned OSCE station, when you get there, the question is written on a paper, boldly, and pasted on the wall, with a simulated patient in front of you. You only start work when the bell is rung to start. And so before the bell goes, you have the chance to be organizing your thoughts after reading the question. This is the best time to relax and generate some common differential diagnosis. And so in your head, you are asking, what can cause an acute or a short duration chest pain and hemoptysis in an elderly man? Now, the time allowed for this manned OSCE station is 10 minutes. We have 7 minutes to take a focused history, meaning a diagnostic history, and then 3 minutes to present our history and answer some questions which our examiner will ask. And so we need to compose ourselves and flow, but we should be very swift. Now this may look very intimidating, but what you need to know is that with practice, you will become good at this skill. Now, when the bell goes to start work, it is important we compose ourselves and use just 30 seconds to write out the various blocks or the various components of history taking on the paper. And so for demography, you quickly write demo, then followed by PC, which is the presenting complaint, then HPC, which is the history of presenting complaint, then on direct questioning as ODQ, systemic enquiry SE, then the past medical and surgical history, then the drug history, social history SH, family history FH, and if the patient is a lady or a woman, we add the basic OBGYN history. The reason for doing this is that you do not skip any step in the history taking because of exam fright. Because remember that each of these components have marks or has marks, I should have said, allocated to them. And so in order not to forget or skip any of them, you quickly use the first 30 seconds, to write them out. It may seem like you've wasted time, but it is really worth it. And so please take note of that. Now, another tip is that it is not necessary to write out complete sentences when taking this history. For example, if the patient says there is no fever, you don't have to write there is no fever because this will waste time. You can just put fever, not, or maybe fever minus. If there is a history of jaundice, you don't have to write there is a history of jaundice. No, you have no time for that. You just write jaundice plus. This is to buy time or to save us from wasting time because of unnecessary writing. Very good. And so with these tips in mind, we begin our exam. The first step is to establish rapport. Okay, and then here the examiner is looking at your courtesy and then your politeness. Talking to the patient, are you being professional? So there are marks allotted for this part, and so do not skip it. Establish rapport. And so here I expected the candidate, which he did. I expected him to go something like this. Good morning, sir. How are you doing today? My name is, and then you mention your name. My name is Justice Mumuni, a medical student. I have been asked by my superiors to take some history from you. Please, do I have your permission? And so here, it is expected that you are polite, greet the patient, introduce yourself, and then introduce or tell the patient your rank in the team. And then tell the patient why you have come to him, that you have been asked by your superiors to take history from him. And does he give you his permission? And so you do this very quickly. You don't have to spend a lot of time here. And so again, good morning, sir. Very fast. Good morning, sir. How are you doing? My name is Justice Mumuni. I'm a medical student and I have been asked by my superiors to take a history from you. Please, do I have your permission? Once you do this excellently, the examiner takes a column, meaning that you have established rapport. You did not skip this point, and so you get the marks that is due you for this step. Very good. And so remember, you have created a template on your sheet, and so from rapport you move to patient demography. That is step 2. Now here you want to know the patient's name, the patient's age, whether the patient is married or not, or whether he is widowed or not. You want to know his religion, where he lives, and then the thing or the occupation of the patient. And so you go like this, very courteously. Sir, please, may I know your name? The patient tells you his name. Kwesi Poku. How old are you, sir? The patient tells you his age. I'm 65 years old. Please, are you married? He says, yes, I'm married with 2 children. What is your religion, please? He says, oh, I'm a Christian. Sir, please, where do you live? And what is your occupation? He says, oh, I live at Kenten and I'm a pensioner now. I was a teacher when I was in active service. And so here, again, be swift, and you should not skip this part of the history. Don't say because the question has given you the patient's the patient's age, you won't ask his age. You have to ask his age because there is marks for this station or for this step. And so please, from rapport establishment, you come to patient's demography quickly. May I know your name? How old are you, sir? Are you married? What is your religion? Where do you live? And what is your occupation? Then we move to step 3, which is the patient's presenting complaints or complaints and duration. Here, please do not make a mistake by thinking that, well, the question has already given us the patient's presenting complaints, and so there is no need to ask questions here. If you do that, you are going to lose the marks allocated for this step. And so, although the question has given you the patient's presenting complaints, you ask politely, please, may I know why you have come to the hospital today? And then the patient would say, oh, I have chest pain. That is all, right? Then, when did it start, please? You are establishing the duration. The patient says, it started 3 days ago. And so the patient gave you his presenting complaint, which is chest pain, and then the duration of the presenting complaint, which is 3 days. Then you move to step 4, a history of presenting complaints. So you simply ask, sir, please, when were you last well? A patient answers, oh, I was well until 3 days ago when I had this chest pain. Then you want to ask, okay, but is there any diagnosed chronic medical condition I have to know? Before this pain started, were you known to have any chronic medical condition? Then, according to the history or the marking scheme, the patient will tell you, well, I had a surgical procedure for prostate cancer about 6 years ago. And so you see, this tells you how the patient was before the chest pain happened. So you want to know the state of the patient even before this presenting complaint came. Was he very well, or he's known to have any chronic medical he's known to have a chronic medical condition before the presenting complaint came? That gives you a very good picture of how the patient has been. Now, like I have always been saying, I need to pause here and then reiterate this point, that usually after the patient's demography and presenting complaints, naturally some differential diagnosis would have to come into your mind. So here you briefly pause, or let's pause here and then generate some differential diagnosis for this patient. What can cause chest pain in this patient based on what we have seen already? And so one, it could be that the prostate cancer has metastasized to the lungs, and so prostate cancer with lung metastasis. Remember, he just said he had a surgical procedure for the prostate CA. We don't know which surgical procedure it is. Then it could be pulmonary tuberculosis because of the cough, and then the hemoptysis, although the duration of the cough doesn't really match typically pulmonary TB, but it could be. Then it could be bacterial pneumonia. Bacterial pneumonia can also give you a chest pain. It could be pulmonary embolism with an infarct. Okay, and then it could also be pulmonary edema, either from a congestive cardiac failure, which is CCF, or CKD. And so, as the history progresses, you would see that one of these 5 fits the patient's description. Okay, so when you are taking the history, you have to be on the lookout for points that may suggest one of these diagnoses. And so my point, or the point I'm making here, is that usually at the end of the demography and then the presenting complaints, you should be able to make or generate some differentials. When you get to the history of presenting complaints, just a few steps into the history of presenting complaints, naturally you should be able to generate some differentials. So we are saying that these are the 5 possible differential diagnoses that we should be thinking about. Very good. And so please do not forget to like and share this video and subscribe to our channel if you have not done that yet. Now we need to continue with our history of presenting complaints. The presenting complaint was chest pain, and so we need to describe the pain using Socrates. Remember, we have discussed this in our medical history taking video. And so you ask the patient, "Sir, please, where is the pain located?" The patient says, "Oh, it's in my right chest, please." Then, you want to know whether it began suddenly or gradually. So you ask, "Please, did it begin gradually or suddenly?" The patient's answer is, "It came gradually." Then you move to the character of the pain. So politely you ask, "Can you please tell me how the pain felt like? Was it tightening?" You suggest some terms. Was it tightening or sharp, or it was burning? Then you give the patient a chance. "Can you describe it?" And the patient gives you an answer. It was a sharp pain. And then once you start getting some of these responses, you know which of the diagnosis you've generated is most likely. And then, as you know, the R in Socrates stands for radiating or radiation sites. So you want to ask, "Sir, does the pain radiate anywhere else?" The patient's answer is no. Then A for associated symptoms. So you want to ask, "Sir, are there any symptoms associated with the pain?" Then the patient answered, "Yeah, I cough, sometimes with blood-stained sputum." Then T for timing. You want to know, "Sir, how long does the pain last, and is there anything that triggers it?" The patient responds, "It lasts for about 20 minutes or more, and no, nothing triggers the pain. Then you come to E, exacerbating factors. So you ask, is there anything that worsens the pain, sir? Then the response the patient gave us, not that I have taken note of. But you want to find out if the pain is pleuritic. And so you ask, but does the cough or deep breathing in worsen the pain? The patient says, yeah, doc. This makes the pain pleuritic. Then S stands for severity, and so you ask politely, sir, if 1 were the least pain you felt and 10 were the worst pain you felt in your life ever, how will you score the pain? How would you grade the pain? The patient, having understood this, would say, I would grade it out of 10, I would grade it 7 out of 10. And so the pain is relatively severe. And so remember that history of presenting complaint is the series of events which have occurred right from the onset of symptoms till when the patient came to see you in a chronological order. So you want to know if the patient has been somewhere else seeking medical attention before coming to see you. And so you ask, sir, please, did you seek any medical care before seeing me? The patient says, no, please. The medical care in this sense may be a prior admission to a peripheral facility, or going to a chemical shop to get some medications for the said symptom. And so you want to know that as well. Did you seek any medical care before coming to see me? Then right after completing the history of presenting complaint, you come to step 5, which is the undirect questioning. This session seeks to get the cause of the patient's presenting complaint and whether there are any complications from the main diagnosis you are thinking of. And so, thinking that it could be a metastatic prostate CA, we want to ask questions to justify that. But kindly note that prostate CA usually spreads to the spine. And so, we want to ask if there is any lower back pain. So the patient had a lower back pain. There was no breathlessness. And then since we are thinking that it could be pulmonary TB, we want to ask about weight loss, although weight loss can also occur in prostate CA. And the patient had weight loss. We want to ask about night sweats. He had no night sweats. We ask about fever. He had fever. And then still on the justification, or still on arguing a case for TB, the patient had no contact with a chronically coughing patient. Then we are thinking that it could be pulmonary embolism. And so we want to know whether there was any unilateral leg swelling, which could suggest an antecedent DVT. The patient had no unilateral leg swelling. Then say, have you had any long distance travel recently? Patient says no. We are thinking that it could be pulmonary edema, which can cause pink frothy sputum from either heart failure or chronic kidney disease. And so we want to ask about symptoms of pulmonary edema. Sir, do you have autopnea? The patient didn't have autopnea. The patient didn't have paroxysmal nocturnal dyspnea. And then the cough did not worsen when the patient laid on his back. And so these are important ODQ questions to ask. As for the case of pneumonia, the fever, the breathlessness, the chest pain, all have been asked, and so there is no need to repeat those questions again. Very good. And though unlikely, it could be chest pain of cardiac origin. It could be from acute coronary syndrome, but the nature of the pain described in the HPC does not make this likely, but we still want to ask questions to be sure. And so we ask about nausea, excessive sweating, which the patient didn't have, faintness, etc. And so all these were negative, confirming that it is unlikely to be acute coronary syndrome. And so right after completing your ODQ, you want to do your systemic enquiry, which is step 6. And so here, you note the various systems and then ask at most 3 questions. You don't have to spend time here. You can even ask 2 questions under each system. And so beginning with the cardiovascular system, you want to know, please, are there any palpitations? He says no. Any dizziness? He says no. Any claudication? He says no. Then we move to the respiratory system. Please, is there any history of a wheeze? He says no. Runny nose? No. Quickly, we move to the GI, the gastrointestinal system. Is there any history of diarrhea? He says no. Any constipation? He says yes. Any vomiting? He says no. Then we move to the genitourinary system. Please, is there painful urination? He says no. Is there frequency? Do you urinate more often than before? He says yes. Do you have the feeling of maybe urinating on yourself if you don't rush to the washroom anytime you feel the need to urinate, which is urgency? He says no. Then you come to the neuro or neurological system. There are no headaches, he says. Is there any weakness? He says no. Is there any numbness or feeling abnormal sensation in any part of your extremity? He says no. Then you come to the skin, the integumentary system. Please, is there any rash? He says no. Any body itch? He says no. That is pruritus. No. Then the musculoskeletal system. Sir, is there any joint pain? He says no. Any ankle swelling? He says no. Any muscle pain? He says no. And so you don't have to spend a lot of time here. You just ask just 2 questions under each system and then move on. Very good. And so please do not forget to like and share this video and subscribe to our channel if you are here to do that. After completing your systemic enquiry, you move to step 7, which is the past medical and surgical history. The patient has given you a hint that he was diagnosed with prostate cancer. Here, one of the questions you want to know, or you want to ask, is, sir, is the prostate cancer biopsy proven, please? Because some patients can just tell you that they have prostate cancer when they've not had any biopsy. Then the patient's response is yes. Then you can go further. How was the biopsy taken? He said, I was just told that I should send a biopsy to the pathologist. Then you know that yes, it was biopsy proven. Then the patient said that he has had a surgical procedure done for the prostate CA. So you want to ask him to be sure. You asked him, sir, what surgical procedure was done for the prostate CA? And interestingly, the patient gives a response that they passed something through my rectum and I could hear some sounds. And so quickly, you notice that the patient did not have any definitive surgical procedure for the prostate CA. What he's describing as a surgical procedure is actually the true cut biopsy transrectally. And so the procedure was just to take some biopsy for him for the confirmation of the prostate CA. Then you ask, sir, apart from the prostate CA, which you've already told me, is there any other medical condition I should know about, like hypertension or diabetes? Any that I should know about? The patient's response is none. Apart from the prostate CA, none. After the past medical and surgical history, you move to step 8, which is drug and allergic history. So politely, you ask, "Sir, please, are you on any medications I should know about?" The patient's response, "I was given a drug called Casodex." Then you want to go further and ask, "Please, do you know the dose?" Patient says, "Oh, I can't remember. Forget that and then move to the next question. How about any herbal medications or OTCs? OTC stands for over-the-counter medications. Do you get any medications from the pharmacy? He says, "Yes, for the herbal preparations, I take some orally, but I don't usually buy drugs from pharmacies. So there is no history of over-the-counter medications." Sometimes you'd also want to ask about any IV drug usage. Okay. Then another question under this session to ask is, "Sir, please, are there any drug and or food allergies you think I should know about?" Patient's response is, "No, please. There are no drug or any food allergies." Very good. And so you move to step 9, which is social history. Now here, remember, you want to know where the patient lives, whether he's married or not, the children he has, what he does for a living. But these questions, remember, have been asked in the demography, so there is no need to repeat them in the social history because you'll be wasting time. So other additional questions you should be asking for the social history is alcohol use, cigarette smoking, recreational drug use, whether or not he's on insurance, and then if he accepts blood. Okay, and so question, "Sir, please, do you drink alcohol?" Patient says no. Then about the cigarette smoking and then the recreational drug use, it is a very sensitive area, so you need to word your sentence politely. And so one way to ask that is, "Sir, can you please be kind enough to let me know if you smoke cigarettes or use any recreational drug, or maybe you have used any of them in the past before?" Patient says, "No, please, I don't smoke cigarettes and I've not used any recreational drug." Then, "Sir, please, are you on the National Health Insurance Scheme?" He says yes. "And is it active?" He says yes. "Please, do you accept blood?" He says yes. Then you come to step 10, and because this patient is a man, this would end the history for you. If he were a woman, or if the patient were a woman, you would be asking some basic obstetric and gynecology history. And so step 10 is the family history. You want to know, "Sir, please, is there any history of a chronic medical condition in the family?" He says no. Like diabetes, hypertension? He says no. "Was your dad also diagnosed with prostate CA?" He says no. "Okay, are your mom and dad alive and well?" He says no, they are all deceased. "I'm 65 years old, so all right." Then you want to ask, "Sir, please, do you have any siblings?" He says yes. "How many of them?" He says 3. "Okay. And you are number?" He says, "Oh, I'm the first of 4 siblings." You want to ask, "Are all of them alive and well?" He says yes. And so this would end your history. And so with this, you have taken an above average history for an OSCE, for a 7-minute OSCE. So from here, you need to move to your presentation, and that is the next step. And so after you are done with your history taking, as I mentioned earlier, the next step is history presentation. And so here, you quickly turn to the patient. "Mr. Poku, please, I want to discuss my findings with my superior, if you will." Because remember, you are honoring the medical ethical principle of patient confidentiality. You can't just break someone else's news to a third party without the patient's permission. And so you have to do that. Then you turn to your examiner and then start presenting. So I'm going to present this case based on the history we took. So I begin. "I present 65-year-old man, Mr. Kwesi Poku, a pensioner, a Christian, married with 2 children, and lives in Kenten. He presented with a right-sided chest pain of 3 days duration. And so here, as you can see, this presentation has covered the patient's demography and then the patient's presenting complaint and duration. The pain was gradual in onset, sharp and pleuritic, and did not radiate anywhere. It had no relieving factors. It was associated with hemoptysis. The pain lasted for 20 minutes and was graded 7/10 for severity. On direct questioning, there is a history of weight loss and fever, but no drenching night sweats or contact with a chronically coughing patient. There is a history of lower back ache, no dyspnea, no history of long distance travel or prolonged immobilization, and there was no history of an antecedent unilateral leg swelling. There is no history of exertional dyspnea, orthopnea, or paroxysmal nocturnal dyspnea. Systemic enquiry was clinically unremarkable except for constipation. For his past medical history, he has a true-cut rectal biopsy-proven prostate cancer, which was diagnosed 6 years ago. There is no other medical condition, no previous admissions, no blood transfusions. For his drug history, he was put on Casodex. He occasionally takes oral herbal preparations and does not use any over-the-counter medications. There is no known drug or food allergies. For his social history, he does not take alcohol. He neither smokes cigarettes nor uses any recreational drugs. He is on NHIS and it is active. He accepts blood transfusions. His mom and dad are deceased. He is the first of 4 children, and all 3 siblings are alive and well. There is no family history of any chronic medical condition. His dad was not diagnosed with prostate CA, or there is no family history of prostate CA. And so once you are done with your presentation, your examiner would want to know your most likely diagnosis. And here, saying that prostate CA or prostate cancer with lung metastasis is a reasonable diagnosis. Then the immediate question that usually follows is, did you consider any other differential diagnosis? Your response, yes please, I did. I considered pulmonary tuberculosis, bacterial pneumonia, pulmonary embolism, and it could be pulmonary edema from congestive cardiac failure or CKD. It could be acute coronary syndrome. So in that order. But usually, sometimes they will just ask, what is your diagnosis? You give, and then they will want you to mention more. So if you mention at least 4 reasonable differential diagnoses, you are above the average candidate. And so still on the diagnosis defense, another question can be, what in your history supports your main diagnosis? For any diagnosis you choose as your main diagnosis, you would have to defend the diagnosis. And so here, reasonable responses include the fact that the patient had a biopsy-proven prostate cancer. It is not a suspected one, but a biopsy-proven one. The fact that the patient has lower backache tells you that there is vertebral or there may be vertebral metastasis, and so it can give an idea that the prostate cancer has started spreading. So it is no wonder that it has gotten to the lungs. And then the fact that there is weight loss, as you know that weight loss characterizes a lot of malignancies. Then your examiner might go to one or two of your other differential diagnoses and then ask you the reason why it may not be those differential diagnoses. And so one question is, what in the history did not support pulmonary tuberculosis or PTB? Then you can mention things like the duration of the cough did not support that. As you know, typically, although not always the case, but typically a TB cough lasts for more than 2 weeks or for 2 weeks or more. It's a chronic cough. Then the fact that there are no drenching night sweats also did not support the probability that it could be TB. And the fact that the patient had no contact with a patient who was chronically coughing, or no contact with a patient who has been diagnosed with TB. So all these in the history did not make TB likely. But it doesn't mean it cannot be TB. It can be TB, but based on the available evidence in the history, TB seemed unlikely. And please endeavor to say pulmonary TB instead of just saying TB, because as some of you may be aware of, we have extra pulmonary TB and then pulmonary TB. And so being specific in exam would cut off the need to be asking or to being asked follow-up questions for clarity. And so always be specific and sure of the answers you gave. Then the examiner asked this question. Now, assuming the diagnosis were bacterial pneumonia, how would you investigate these patients? Now, this tells us that if candidate A goes to take this history, his line of questioning may investigate or may toe along the line of discussing prostate cancer. Candidate B would also have another line of questions which may be discussing PTB. So it doesn't mean that all of you will have the same case to discuss. The examiner has the liberty to choose any diagnosis he wants to discuss. So assuming that the diagnosis were bacterial pneumonia, how would you investigate this patient? Then a reasonable response should be, say, please, the investigations can be grouped into diagnostic and supportive investigations. And so for diagnostic investigations, since I'm thinking about bacterial pneumonia, I would want to do a plain chest radiograph. The plain chest radiograph may show lobar opacifications that may indicate consolidation. Again, the plain chest radiograph may help me rule out the prostate CA, which is my differential, because the plain chest radiograph may show cannonballs. Then, apart from the plain chest radiograph, I would also want to take some sputum for culture and sensitivity to culture any bacterium or bacteria. Then, other supportive investigations include full blood count, which may show increased white cell count, which is indicative of an infection, particularly an increased neutrophil count. Also on the sputum, since I'm thinking of TB, apart from sending the sputum for culture and sensitivity, I would want to do some smear for acid-fast bacilli and to do some gene expert to rule out TB rule out TB. Then I would want to do a blood urea electrolyte and creatinine, because I would need the urea to determine if the pneumonia is severe or not in the KEP 65 score. I would also want to do an ESR, because ESR is a marker of inflammation, and typically ESR levels more than 100 or 150 may suggest pulmonary TB. And so you say that my investigations can be grouped into diagnostic and then supportive investigations. Please do not say I will do a plain chest radiograph waiting for the examiner to ask you what are you looking for. No, once you say it, plain chest radiograph, you give some suggested findings. Once you say full blood count, don't wait for the examiner to ask you what are you looking for in the full blood count. It's sometimes infuriating for them, and it may waste your time if you are waiting to be asked follow-up questions. And so keep practicing like that. Then, the last question usually is, how will you manage this patient? A reasonable response would be, sir, please, I will determine the severity of the pneumonia using the KERP 65 score, and that would help me decide if I should admit this patient or should manage this patient on OPD basis. If the KERP 65 score shows a mild pneumonia, that is from 0 to 1, anything 0 to 1, I'll treat the patient on OPD basis with appropriate oral antibiotics, preferably amoxiclav, and maybe a macrolide like azithromycin, and then refer the patient to see his urologist since he has prostate CA. Now, if the pneumonia is severe, evidenced by a KERP 65 score of 2 or more, I would want to admit the patient and then treat with appropriate antibiotics, and then call for a GU or a urology consult. If the KERP 65 score is 3 or 4 or even 5, the patient might need ICU admission. So that is how you would manage the patient. Of course, the antibiotics would address the infectious particle, but you need to treat the symptoms. If the patient has fever, you need to give IV paracetamol. If the patient, I'm talking of those on admission, and even those on OPD basis, you can give oral paracetamol. If the patient is going to be bedridden, you need to do some DVT prophylaxis by giving some heparin and then all that. Very good. And so on this slide, I would want to give some tips or some pearls in history taking, some advice for the OSCE exam. Please, this cannot be overemphasized. Practice frequently. Get the common complaints in medicine like headache, chest pain, cough, seizures, and so on, breathlessness, and then practice how to take their histories. It is very simple if you practice and get used to it. Then, second point, I've already said it, but I want to reiterate it. Know how to collect common complaints. I've already mentioned them. And then I want to say that each component has allocated marks. So do not waste time on one. Do not waste time on presenting complaints and then history of presenting complaints, and then make sure your exam gets to management, because history taking has 50 marks, and then history presentation and answering questions also have 50 marks. And so unfortunately, if you make time beat you on just history taking, you are going to be marked over 50 and you are going to lose precious 50 marks for the history presentation and then answering questions because you never got there. Please, for the fourth point, maintain a good composure. Once you maintain good composure, it builds up your confidence and it makes you even remember the things you've learned. Agreeably, it is not going to be an easy atmosphere, but maintain a good composure. And then the last point is that do not forget the illness scripts of diseases. I mentioned this in the very first video we posted on this channel, that for medical conditions, get their illness scripts. An illness script is made up of the signs and symptoms of a condition and its risk factors. So once you know these, you can guess the possible diagnosis. To give an example, the illness script for myocardial infarction is made up of signs and symptoms. So I'm beginning with the symptoms like chest pain, crushing chest pain, which radiates to the neck, jaw, associated with anginal equivalents like nausea, vomiting, palpitations, dyspnea, easy fatigability. Then the risk factors include hypertension, obesity, diabetes, cigarette smoking, sedentary lifestyle, etc. So once you know these, whenever you are given a patient with chest pain, you know the questions to ask because you have the illness scripts in your minds. So thank you for watching this episode of TutorMed. Please do not forget to like and share the video and subscribe to our channel if you have not done that yet. So see you in our next video, and until then, bye, arrivederci, au revoir.